Dear students, welcome to you all today's pathology session. I am Dr. Asma Hosna, Associate Professor, Department of Pathology, Bashundhara Ad-din Medical College. Today I am going to discuss a new topic, that is endometrial hyperplasia. What is endometrial hyperplasia? Endometrial hyperplasia is defined as an increased proliferation of an endometrial glands relative to the stroma, resulting in an increased gland to stromal ratio when compared with normal proliferative endometrium. What about the clinical significance of endometrial hyperplasia? The endometrial hyperplasia deserves special attention because its relationship with endometrial carcinoma. That means from the endometrial hyperplasia, endometrial carcinoma may develop. Now the pathogenesis, how this endometrial hyperplasia is developed. The endometrial hyperplasia is associated with prolonged estrogen stimulation of the endometrium with diminished or absence of progesterone activity, and this occur due to anovulation, increased estrogen production from endogenous source or exogenous estrogen. There are also some associated factors for endometrial hyperplasia, and that include obesity, menopause, polycystic ovarian disease, functioning granulosa cell tumor of the ovary, excessive cortical function, prolonged administration of estrogenic substance, that means estrogen replacement therapy, and it occurs most commonly around menopause or in persistent anovulation in younger women. Now come, what are the current classification of endometrial hyperplasia? The classification based on the architectural and the cytological features, and the endometrial hyperplasia is divided into two major categories. One is non-atypical hyperplasia and another one is atypical hyperplasia. What is non-atypical hyperplasia? In case of non-atypical hyperplasia, there is increased in the gland to stromal ratio, and the glands show variation in size and shapes and may be dilated. And in case of atypical hyperplasia, it is composed of complex pattern of proliferating glands displacing nuclear atypia, and the glands are back to back with complex outlines due to branching structures, and the cells become rounded and lost the normal perpendicular orientation to the basement membrane. So the atypical hyperplasia, also known as endometrial intraepithelial neoplasia. The significance of endometrial hyperplasia is there is increased chance of endometrial carcinoma, abnormal uterine bleeding and infertility. What are the tumors of uterine wall? We know there are two components of the uterine wall. One is endometrium and another one is myometrium. And the endometrium is composed of endometrial glands and the stroma, and the myometrium is composed of smooth muscles. So from the glands, when the tumor arises, it may be benign or malignant. If it is benign, it is endometrial polyp, and in case of malignant tumor, it is known as endometrial carcinoma. When the tumor arises from the stroma, it is known as benign stromal nodule and stromal sarcoma. Tumor arises from both gland and stroma. It is known as carcinosarcoma and adenosarcoma. And the tumor of the myometrium include Leomyoma, Leomyosarcoma, and most common tumor of the uterine walls are Leomyoma, endometrial polyp and endometrial carcinoma. Now come to our next topics, that is Leomyoma. What is Leomyoma? It is also known as fibroid by the clinician. It is a benign tumor of smooth muscle and it may be present in 75% of the female in reproductive age. Anatomically, the Leomyoma can be classified into submucosal group, which is located just beneath the endometrium, intramural, that located within the myometrium, subserosal, that are located beneath the serosa, and the parasitic Leomyoma. Now come to the gross pictures of Leomyoma. Leomyoma grossly, it is sharply well circumscribed, discrete, round, firm and grey white tumor that may small to large in size. On cut section, it is whole in appearance and is uncapsulated. And histologically, there are presence of whole bundles of smooth muscle cells with fibrous tissue, and the smooth muscles are normal size and shape, and the mitotic figures are square. Now come to the complication of Leomyoma. The complication of the Leomyoma include menorrhagia, anemia that may be macrocytic hypochromic, dysmenorrhea, abortion, infertility, compression of the bladder, fetal malpresentation, uterine inertia and postpartum hemorrhage. What are the retrograde changes that occurs in Leomyoma? It include cystic degeneration, rate degeneration, calcification, hyalinization and necrosis. Then the malignant component of Leomyoma, that is known as Leomyosarcoma. It is a malignant tumor of the smooth muscle cell and it arises directly from the myometrium and also from the endometrium, and grossly it present as a bulky tumor. And this diagnosis of Leomyosarcoma is based on mitosis, nuclear atypia and the zonal necrosis. If there are presence of more than 10 mitosis per 10 high power field with or without any atypia or necrosis, it defined as Leomyosarcoma. And if there are presence of atypia and also more than 5 mitosis per 10 high power field, this also indicate Leomyosarcoma. Then come to our next topic, that is endometrial carcinoma. It is the most common invasive cancer of female genital tract and it accounts for 7% of all invasive cancer in women, excluding skin cancer. And the incidence, it occurs above 40 years and the high is between 55 to 65 years of age. It is also classified into two categories. One is type 1 endometrial carcinoma, that is known as Endometrioid Carcinoma, and another one is type 2 carcinoma, that is known as serous carcinoma. In type 1 carcinoma, it is most common type and approximately 80% of the cases it occurs, and they typically arises from the endometrial hyperplasia, and there are also some association like obesity, diabetes mellitus, hypertension, infertility and unopposed estrogen stimulation. In type 2 carcinoma, they generally occurs in women who are about 10 years older than those of type 1 carcinoma, and this endometrial carcinoma that less commonly associated with hyperplasia, and they usually develop in an older age and poorly differentiated and accounts for 15% of the cases of endometrial carcinoma, and the prognosis is bad. During gross examination, the endometrial carcinoma may present either as localized polypoid tumor or as a diffuse tumor involving the entire endometrial surface. And on histological features, about 80 to 85% of the endometrial carcinoma are adenocarcinoma, and these adenocarcinoma are characterized by more or less well defined gland pattern that are lined by malignant stratified columnar epithelial cell. So, they can be classified into 3 grades, grade 1, grade 2 and grade 3. In case of grade 1, all the tumor cells shows glandular pattern, and so they are classified as well differentiated adenocarcinoma. And in case of grade 2 tumor, that is moderately differentiated tumor, the tumor are formed gland or glandular pattern with solid sheet of malignant cells, and by definition up to 50% of the cells are from solid sheet. And in poorly differentiated carcinoma, that is known as grade 3 adenocarcinoma, the maximum more than 50% of the tumor cells show solid sheets of cells and few tumor cells show glandular pattern, and up to 20% of the endometrial carcinoma show squamous differentiation. That is all about today's lecture, my dear student. Inshallah, see you again in our next class. Till then, Allah Hafiz.